You know, the topic is regarding the obesity in childhood. As you know, charity begins at home, so is the obesity. So, this is 8-year boy, and we will learn childhood obesity from Dr. Alpesh Goyal, and he will tell about the various causes about obesity and in children and how it goes into the adults. Lifestyle modifications will be needed there, and we find the causes in childhood to remove it. Dr. Goyal, please.
Thank you, respected chairpersons. Good afternoon, one and all. The topic that I have been assigned is childhood obesity in 8-year-old boy. And at the outset, I'd like to thank Team Speed for inviting me to this reputed academic conference. So, can I have my slides? Thank you. So, it's a case-based approach. So, I'll start with the case vignette, and then I'll begin with definition of childhood obesity. When to suspect a secondary cause, because the routine garden variety of obesity is what I will dwell in my talk, but I'll also discuss what are the points when you should suspect a secondary cause, risk factors and challenges, management approach, and because this is about writing a prescription, so I'll dwell into that as well. So let's begin with the case. So it's a 8-year-old boy. Parents have brought saying that this child has always been little chubby, but he is having progressive weight gain for last 2 years during this pandemic when lockdown restrictions started. Obviously, he's having sedentary lifestyles and poor eating habits. Both parents are either overweight or obese. He's not on any medications, right? So his weight is 35 kg, which is at 90th to 97th centile as per the IAP growth charts, and we can see his height is preserved. In fact, he's relatively tall for the general population. Height is 135 centimeters, and is also relatively tall for his mid-parental height. That is, he is tall for his genetic potential as well. BMI is 19.2 kg per meter square, and what is the connotation of this BMI we'll discuss. The physical examination is grossly unremarkable. There are no dysmorphisms, and general and systemic examination is also normal. Okay. So before I go on to this case, I'll just like to bring home the point that childhood obesity is an important problem, not only in Western world, where about 1 in 3 children or adolescents are affected by overweight and obesity, but also in Indian setting, where according to this systematic review, nearly 1 in every 5 children and adolescents are affected by overweight and obesity, and there is a clear trend, as was evident from this systematic review by Ranjani H. et al. So how do we define obesity in children? How is it different as compared to adults? So moving on to general definition of obesity, we know that obesity is abnormal accumulation of body fat that presents a risk to one's health. Now, measuring body fat using sophisticated techniques is not cost effective, and nor is it feasible on bedside. So we have used BMI for times immemorial, and this is a good surrogate for body fat, despite it having its limitation that it cannot differentiate between adipose tissue and muscle tissue. It has been used in pediatric and adult clinical practice with good effect. For adults, you can use definite BMI cutoffs which are associated with increased health risk. For example, BMI of more than 25 and 30 in Western population, and BMI of more than 23 and 25 in Indian population or South Asian population. However, because children are growing, you cannot use a fixed BMI cutoff, and the BMI will change with age. So you have to use a dynamic cutoffs based on age and gender based cutoff values, and that is something that you can use from 2 years and beyond. So if we see the definition of childhood obesity according to Center for Disease Control and Endocrine Society, if you have BMI between 85th to 95th percentile for that age and gender, you can define that child to have overweight. And if BMI is more than 95th centile, it can be defined as obesity. Further, the definition for severe obesity or a grade 2 obesity is BMI more than 120% of 95th percentile, and a BMI more than 140% of 95th percentile is defined as stage 3 or severe obesity stage 3. But what is the problem with these definitions? Actually, these definitions have been based on arbitrary cutoffs. They are not related to specific health risk as in adults, and they also do not account for the secular trend of increasing weight in populations worldwide. So by that I mean that because childhood overweight and obesity is increasing, the mean weights are also increasing. So in that scenario, there is a risk that you may classify a normal weight child as underweight and a relatively overweight child as normal weight. So to address this lacunae, International Obesity Task Force has come up with a new definition which defines BMI cutoffs which correspond to adult BMI of 25 and 30 kg per meter square. And this is based on the premise that future health risks of childhood obesity are mediated through adult obesity, and there is tracking of obesity and relative behaviors to adulthood. So that does mean that a person who is obese at 18 years is likely to have tracked his or her BMI from the very childhood. And that is what is shown in this diagram, that if you see there is a tracking of BMIs, and if you want to define obesity at age of 8 years, you can use these cutoffs which correspond to adult BMI cutoffs of 25 and 30 kg per meter square. So Indian Academy of Pediatrics, based on the IOTF method, has defined new BMI cutoffs, and they have used adult BMI cutoffs of 23 and 27 kg per meter square to use this definition, because we know that South Asian phenotype at a given BMI you tend to accumulate more body fat, and body fat is something which defines overweight or obesity. So these revised IAP growth charts are readily available, and the publication is in Indian Pediatrics 2015, and we can readily access these growth charts. And these growth charts were based on data from individuals between 5 and 18 years and from 14 cities in different zones of the country. So these are representative of the entire country. So if we see, this is the 23 adult equivalent line, and anybody with a BMI above this cutoff will be classified as overweight, and anybody with BMI above 27 adult cutoff will be classified as obese. So when we encounter a child with possible overweight and obesity, our first job is to calculate BMI, which is calculated as weight in kgs divided by height in meter square, and then you tend to look at these centile curves, or you can use at these you can look at this table which is part of the same publication. So our child has BMI of 19.2 kilograms per meter square, and as we can see at age of 18 years, 27 BMI equivalent is 18.8. So the child is definitely obese. This BMI cutoff falls between 120% of the 27 cutoff, so possibly this is a mild form of obesity. And also to define severity, you can use BMI SDS, which is calculated as BMI of the child minus mean BMI at that age, which is 15.5 divided by standard deviation. And so BMI SDS score or BMI Z score is plus 1.48. Now that is something which is important in context of a follow-up, and that is also important in context of randomized studies. When you have intervention studies for some drugs, you want to define BMI SDS change. Now once you have defined obesity and its severity, it's important to look for any secondary cause. The most common cause of obesity in routine clinical practice is exogenous or simple form of obesity, and this form of obesity is contributed by environmental factors such as dietary factors, physical inactivity, and also genetic factors that relate to overweight or increasing body weight. Now this form of obesity is polygenic and multifactorial. That means that multiple factors come into play, and the intervention also has to be multifactorial. However, we have to look for certain secondary causes, and there are certain clues for each of these secondary causes which I will discuss. So what are the secondary causes of childhood obesity? These include monogenic cause, which means a single genetic cause is at play, including MC4R, leptin and leptin receptor defect. Syndromic causes such as Prader-Willi Syndrome, which is the most common syndromic cause of childhood obesity. Endocrine causes such as hypothyroidism, Cushing's, growth hormone deficiency, and pseudohypoparathyroidism. Drugs including glucocorticoids, which are not very uncommonly used, especially in rural practice. Tricyclic antidepressants, certain antipsychotic drugs, especially drugs like clozapine and olanzapine. Depression and eating disorders should always be ruled out. And then there could be a component of hypothalamic obesity, especially after tumor resection in patients with craniopharyngioma or diencephalic syndromes. So what are the clues for syndromic or genetic forms of obesity? So first and a most important clue is an early onset of obesity. If the obesity is extreme or severe and it had its onset within first few years of life, especially within first 2 to 3 years of life, associated with extreme hyperphagia or extreme appetite, insatiable appetite, and some peculiar behaviors, for example, stealing or eating non-eatable food items like garbage. So that kind of behavior should always be inquired. Presence of short stature and reduced growth velocity goes in favor of syndromic or genetic causes of short stature, and for that matter even endocrine causes of short stature. Presence of developmental delay, intellectual disability, all of this should be inquired. Presence of dysmorphism such as polydactyly, small hands and feet, short metacarpals, all of these are important: hypotonia, feeding difficulties, retinal changes such as night blindness, pigmentary retinal dystrophy, deafness, and hypopituitarism, which can be present to a varying extent in monogenic causes as well as hypothalamic causes of obesity. So this is just a photograph which shows that a child with Prader-Willi syndrome who has hypotonia, very poor feeding, and you can see there is need for assisted external feeding, and after 1 to 2 years of life they have rapid weight gain with insatiable appetite, and they can have severe generalized obesity, but this can very well be controlled if proper dietary and lifestyle measures are employed. Another scenario of Bardet-Biedl syndrome, where you can see the presence of post-axial polydactyly. Now this is a dysmorphic feature that you can see along with hypogenitalism and hypogonadotropic hypogonadism, dental issues, and you can see here there is pigmentary retinal dystrophy. So that is something that you should look for in on an indirect ophthalmoscopy. Another important cause of monogenic obesity, which is MC4R monogenic obesity, as I have discussed. This is the most common monogenic obesity form, and this is a child who had presented to our institute at age of 5 years, but having weight gain and hyperphagia since 6 months of age. So you can see the onset is very early and has presented with BMI of 39.6, which is a severe grade 3 obesity. Weight is more than 97 centile. However, it's very peculiar to note that even height is preserved. So monogenic obesity, MC4R mutations are one such exception where you can have preserved height, and this was shown in a large case series in JCM, where the authors have found that compared to obese controlled subjects, patients with MC4R mutations have preserved height SDS and in fact increased predicted adult height. Endocrine causes of short stature include hypothyroidism, Cushing's syndrome, growth hormone deficiency, and pseudohypoparathyroidism. Now these are all important to rule out, especially if there is obesity along with short stature. Now hypothyroidism mainly leads to weight gain only in severe forms, and that too due to fluid retention. So strictly speaking, because it's not increased body fat, it should not be classified as a cause for overweight or obesity. Cushing's syndrome in pediatric age group, it's very peculiar that you may not get catabolic features that you get in adults like striae or ecchymosis. In pseudohypoparathyroidism, you tend to get short metacarpals, and in growth hormone deficiency, you can get short stature with cherubic facies and increased prepubertal fat deposition. However, we have seen that Indian children, you may not always get obesity in patients with growth hormone deficiency. So what are the challenges, what is the risk factors, and how should we approach a patient with childhood obesity? So first and most important challenge that I have already discussed is that childhood obesity does not remain limited to childhood, it tracks to the adulthood. So as was beautifully shown in this study, that BMI percentage percentile at 5 years correspond to BMI percentile at 14 years. So this was shown that if the child was obese at 5 years, there is 50% probability that the child will remain obese at adolescence. And if the BMI percentile is more than 99, that is, there is a severe form of obesity, the probability of it remaining or persisting is as high as 70%. So that is why it needs to be looked into right from the very early age. Now, what are the factors that govern tracking of obesity into adulthood? So most important, as we discussed in the previous slide, is severity of obesity. If obesity has its onset or has its persistence in adolescence, it is likely to persist into adulthood. And if there is parental obesity, then also it is likely to persist. Challenges, more important challenges are comorbidities. We know that childhood obesity is associated with cardiometabolic disorders such as youth onset type 2 diabetes, which is increasing in rapid proportions in our country, dyslipidemia and non-alcoholic fatty liver disease, NASH, and these should be appropriately screened using tests such as oral glucose tolerance test, lipid profile in a fasting state, and measurement of transaminases. Musculoskeletal disorders, lower limb misalignment, cancers, and mental health disorders are not uncommon. So coming to risk factors for childhood obesity or exogenous obesity, so sedentary lifestyle, unhealthy eating habits, these are very well known, but two more important risk factors are screen time and sleep duration. And sleep duration is something which is not discussed in clinics, and it's very, very important. Psychosocial and emotional distress, so all those marked in red are something which we can address to a larger extent. Parental obesity, it has been found in studies that presence of one parent with obesity increase the risk of childhood obesity by 2 to 3 times, and both parents, if they are obese, the risk is increased by up to 10 to 15 folds. So most importantly, it is lifestyle intervention, and it has to be both diet and physical activity. most common form of dietary intervention is a hypocaloric diet model where you want to take a 24-hour diet recall, you calculate the caloric intake and then you prescribe a caloric deficit diet. However, it is also useful to have a traffic light model where you have food categories which are color coded, and then you can define categories green, yellow or red, which can be taken more frequently or which have to be taken very rarely. Now, in terms of dietary approaches, it is important that the child and the parents see a dietitian and they talk about various aspects of a healthy diet. Physical activity, what is recommended is at least 1 hour of moderate to vigorous intensity physical activity along with cutting down of screen time. Now, everything is evidence based, and whether lifestyle intervention leads to reduction in BMI. So the answer is yes, and this is the results from a meta-analysis of various RCTs which shows that although the BMI reduction is modest, but successful lifestyle intervention can lead to BMI reduction of up to 0.9 to 1.3 kg per meter square over a period of 1 year. Now, screen time and its ill effects. Screen time has shown definite association with childhood obesity, and this is again a meta-analysis which shows that if there is a screen time of more than 2 hours per day, there is 67% increase in risk of childhood obesity as compared to a screen time of less than 2 hours per day. So again, screen time is something which has been clearly shown to be associated with childhood obesity. However, whether intervention in terms of screen time reduction is successful, answer is no. Screen time intervention reduction alone is not successful as was shown in this meta-analysis. So what should be recommended is not only screen time reduction, but it should be complemented with increase in physical activity. So screen time reduction of less than 2 hours per day along with at least 1 hour per day of moderate to vigorous intensity physical activity is something that is important. Sleep duration is another thing that has been associated with childhood obesity in various studies, and this is a meta-analysis which again of various prospective cohort studies which again shows that if there is short sleep duration, which in this context of this meta-analysis is defined as something less than 6 to 9 hours, was associated with increased risk for childhood obesity, and this was statistically significant. Unfortunately, sleep time improvement intervention studies are very difficult to perform, and there is no clear data that emerges out whether sleep time increase leads to improvement in childhood obesity. What can be recommended is good sleep hygiene and adequate sleep duration, which for an 8-year-old boy is somewhere between 9 to 12 hours per day. So that is something that should be inquired in history taking. Now, all interventions in childhood obesity should not only be directed at the child, but should involve family, and it has been shown in studies that family level interventions are much more effective, and this is again a very good document by Indian Academy of Pediatrics, which is not directed at children, but it's directed at parents. So it talks about what parents need to do to tackle childhood overweight and obesity. So first thing that they talk about is that in general we talk that in all chronic metabolic diseases, parents should be their role models for their children, and this is same thing that they talk that parents are children's role model. So not only children have to be physically active, but their parents also have to be physically active. In fact, they have talked that if there is any television in parents or child's bedroom, it should be removed, and meals along with TV should be strict no. And also intervention at the level of community is something that is important, should provide conducive and safe environment to have physical activity. That is again very, very important. Now, because we have talked about non-pharmacological interventions, I'll also dwell about pharmacotherapy. So the role of pharmacotherapy in management of childhood overweight and obesity is very limited. It's limited mainly to adolescents. And as in adults, when we start overweight obesity pharmacotherapy, we have to re-evaluate. And if at 3 months the treatment targets are not being met, we have to stop therapy. So in children, we have BMI based cutoff. So if there is less than 4% BMI reduction at 12 weeks, you have to stop the therapy and re-evaluate. So what are the drugs that are approved? It's mainly in adolescents. Orlistat, which we know is a gastric and pancreatic lipase inhibitor and works by inducing fat malabsorption or caloric deprivation, can be used at a dose of between 60 to 120 milligrams thrice a day, although the effects are very modest, and it's again associated with adverse effects. Phentermine, which is a selective norepinephrine and serotonin reuptake inhibitor, this can also be used. However, it's not a very popular drug in India because of adverse effects such as tachycardia and hypertension. Now, liraglutide is a welcome addition to the armamentarium in childhood obesity. In fact, I like to tell here that even in pediatric diabetes, type 2 diabetes, liraglutide is now approved at age of 10 years or more. So earlier we had metformin and only insulin formulations. Now liraglutide can be used for adolescent type 2 diabetes, and it has also been approved in last 2 years for treatment of adolescent obesity. Now the clear guideline is that it can be used in children aged 12 years or more. The dose titration is as usual. You start with 0.6 milligrams subcutaneous once a day injection and build up every weekly till the time you can reach up to 3 milligrams dose or the maximally tolerated dose. And the guidelines that are suggested is that BMI corresponding to adult 30 kg per meter square BMI or a body weight of at least 60 kg. I'm sorry, it is END. So this is the landmark trial which shows that liraglutide is effective in children with obesity. Lastly, bariatric surgery. Again, the role for bariatric surgery, even in Western countries, is very limited. It's mainly performed in adolescents. Although there is an increasing trend, but it is still very infrequent. So if you see the number of bariatric surgeries performed in a given center, less than 1% of all procedures are in adolescents. And the two most commonly used procedures are sleeve gastrectomy and Roux-en-Y gastric bypass. Now, most important thing to note is that BMI should be more than 40 or 35 with comorbidities, and there should be physical maturity. So you cannot allow bariatric surgery to be done in a physically immature adolescent, because it is believed that nutritional deprivation that will occur post bariatric surgery can lead to effect on final adult height. So at least 95% of predicted adult height should be completed, or the adolescent should be in tenor stage 4. There should be history of lifestyle efforts to lose weight. Obviously, patient should be motivated, and the family should be very supportive. Obviously, appropriate understanding of risk and benefits is very important. So coming to the last and final slide of my talk. So as we have seen, this is a child aged 8 years who has presented with BMI of 19.2 kilograms per meter square. There are no red flag signs to suggest any secondary cause for obesity. There are no medications. He is relatively tall, not only for the general population, but for his genetic potential. And it is more likely to be exogenous because there is background history of sedentary lifestyle. So this is childhood obesity likely to be exogenous. The management will be multifactorial. This is a multifactorial disease. So you have to involve the dietitian, assess current dietary intake using a 24-hour dietary call, and then advise a caloric deficit, a hypocaloric diet model. A structured diet chart has to be provided, which is individualized to the needs of that person. Along with that, at least 60 minutes per day of moderate to vigorous physical activity, which has to be explained. So any physical activity that increases heart rate, increases respiratory rate is moderate physical activity, and this could include jogging, running, swimming, dancing. So all of these have to be included. Reduce screen time to less than 2 hours per day, and screen hygiene is again very important, because screen time is not only associated with increased risk for overweight obesity, but also ill effects on eyes, such as increased risk for myopia. So a simple rule is that after every 20 minutes you should take a 20-second pause and look at a distant object at least 20 feet away. So that is a good important point. Good sleep hygiene and adequate amount of sleep in this child, it should be at least 9 to 12 hours per day, and should be good quality sleep. And family-based intervention is very important. Involving family is important. The advice can not only remain limited to the child, and parents have to be involved. Parents have to work as role models, and they have to avoid blaming. This is something that we see when they come for follow-up. They may have gained weight, but they will blame their child that they are not following the lifestyle prescription. Goals can be set, and as we have discussed, pharmacotherapy and bariatric surgery are not an option at this stage in this child, and they can be considered only at a later stage. Oh, thank you so much.
Thank you very much, Professor Goyal, for enlightening us about the childhood obesity. Actually, you have correctly mentioned that in common people's mind, the thing is that is the hormone that has to be blamed. But only less than 1% of this population is suffering from endocrine disorder. The childhood obesity, less than 1% endocrine disorders. So, Professor Goyal, can you tell us something about the epigenetics or metabolic programming that happens inside the uterus, and how endocrinologists can play a role in this area? Professor Goyal.
Okay. So, I mean, I have I've not gone into that. So there are, apart from environmental and genetic factors, obviously epigenetics is coming up in big way in all various metabolic conditions. And then maternal malnutrition, maternal undernutrition, low birth weight is something that has been related to adult onset overweight obesity, not only adult onset overweight obesity, but risk for developing metabolic diseases such as polycystic ovary syndrome, early onset puberty, especially in girls. So there is role for epigenetics, and also importantly maternal hyperglycemia that can also lead to epigenetic modifications and lead to change in gene expression such that you have expression of those genes which increase the risk for gaining weight. Breastfeeding is something that is again very important. That is a postnatal intervention. So adequate breastfeeding is something that is important. Those children who are being put on formula feed from very early in life, they are at increased risk for childhood obesity, and this has been seen. And there is a general perception that a child who is chubby is actually healthy, and that perception has to actually change.
Thank you very much. Appropriately answered.
Alpesh. Yeah, I think one thing you mentioned, low birth weight, and low birth weight with the early rapid catch-up growth. I think that is one thing which leads to development of childhood obesity as well as the metabolic perturbations and problems in adulthood. And this has been very beautifully shown by the New Delhi cohort study.
Yes, sir.
New Delhi cohort study has very beautifully shown that I think at the age of 8 years, the catch-up growth and the BMI at the age of 8 years predicts the development of metabolic problems subsequently in adulthood.
Yes.
So epigenetic and other modifications are of course very important. And other than these, I think the most basic things that you mentioned earlier, that the environment that the children are, because for the past couple of years children have been just indoors, the play time is reduced, play area is reduced. I think the basic environment that they are getting exposed to, that needs to be modified. That I think is a very important. Thank you.
Well said.
Dr. Alpesh, I would like to add one comment to it.
Yeah.
We are conducting a school health survey for the last 3 years, and we have certain observations. One observation is that in school children, it's called blue screen syndrome. Blue screen syndrome is the time spent by the children in front of the blue screen. Blue screen is your mobile, your laptop, as well as your television. Especially during the COVID period, the blue screen time has been increased, and this what has resulted into it, indiscriminate use of high carbohydrate diets and fatty diets, especially the fast foods. Number two, there is lack of outdoor activities, especially the aerobic exercises timing has reduced remarkably. Both these factors has put extra pressure on the body and has resulted in obesity.
Yeah, very well said, sir. Screen time, what they see on television, that is also important, and we know what content the children are being exposed to on television, and food is also getting to your house. So there is virtually there is nothing that you need to do. You sit on your couch and you can spend your entire day. And I think these habits come from top down and not from down to up. So parents, we are parents, most of us are parents, and we have to work as role models for our children.
Dr. Goyal, one thing before we close the session, you have said about liraglutide in children who are reducing the weight. What about adults? Can we use fructose in the adults also for reducing weight if they are not diabetic?
Yeah. So it's a very, I would say it's a reasonably good option, provided you select the right kind of patient. So the patient is fulfilling the criteria for pharmacotherapy, has had inconsistent weight, or I would say unsuccessful weight loss with diet and lifestyle efforts. And so we do use liraglutide in adults, and the starting dose is again 0.6 milligrams subcutaneous once a day, and you can build it up slowly, but you have to upfront, you have to make the patient aware that you may get gastrointestinal adverse effects. And I've seen that some patients tolerate liraglutide very well, and some do not tolerate even a very low dose. So that is something that we have to, in fact, even in setting of a well-controlled randomized controlled trial, up to 10% dropout rate is there for drugs like liraglutide. And so you can imagine in routine clinical practice, dropout rate will be very high, and I think we need to persist with it.
It doesn't cause hypoglycemia?
Sir, if it will work to actually liraglutide will cause insulin, I will say glucose dependent insulin release by its incretin effect. So all the agents which cause glucose dependent insulin release, once your glucose levels will come down, the
Thank
insulin
you. Thank you
release
very
will
much,
also
Dr.
come down.
Goyal. I think we are over time, and we now close the session after thanking you and
Thank you,
thanking
sir.
the organizers for giving us this opportunity. Dr. Samir Agarwal. Thank you very much.